And I'll introduce you, if you don't mind. This is Dr. William Chu. He's an assistant professor and clinician investigator in the Department of Radiation Oncology at Sunnybrook Health Sciences Centre and at the University of Toronto. He's also an affiliate scientist in physical sciences at the Sunnybrook Research Institute. And the focus of Dr. Chu's research is in the development and evaluation of innovative, high-impact ablative radiation treatment strategies. One of his main areas of research is stereotactic body radiation, SBRT, and it is an emerging radiation therapy technique. I'm sure many in our audience today may have had some sort of introduction to SBRT, and I know it's of great interest. So thank you for coming today, Dr. Chu, and sharing this with us. I'll let you take it over.
Thank you very much, Christine and Mona, for the invitation to participate in this year's virtual patient forum. Really appreciate the time that in organizing this event, certainly in the context of COVID, and I'll walk you through stereotactic body radiotherapy for renal cell cancer, renal cell carcinoma, in the context of primary kidney cancer, and also in terms of patients who have metastatic cancer. And I'll try to get through the slides, but if anyone has any specific questions along the way, then please feel free to ask, and I'll do my best to navigate this virtual conversation we're about to have. So stereotactic radiotherapy, or SBRT, or SABR, stereotactic ablative radiotherapy, is really not so much a new treatment or technique in radiation oncology, but certainly evolving and getting more use both locally in Ontario, Canada, worldwide, for the treatment of patients with cancer, either in the localized setting or the metastatic setting, particularly in the context of renal cell carcinoma. So for patients who've been diagnosed with localized primary kidney cancer, the standard treatment, or the gold standard of therapy, remains surgical resection or partial or complete nephrectomy, for example, like this tumor here, as you see highlighted by the red arrow. Other therapeutic options or ablative options include radiofrequency ablation or cryotherapy or freezing and thawing to basically knock out and kill these types of tumors with what we call thermal, whether it be high temperatures or ultra-freezing temperatures. But still, the standard of care remains surgery. However, there is a large number, a population of patients who have multiple medical conditions that precludes them from having surgery, or the ablative options such as increasing size lesions that are well beyond 3, 4, 5 centimeters in size, or based on their location close to the renal hyla or the renal pelvis, or adjacent to other structures that kind of preclude them from the other ablative options like radiofrequency ablation or cryotherapy. Stereotactic radiotherapy is basically this technique where we're able to really focus in and hone in high doses of radiotherapy in 3 to 5 sessions to a specific target. We're utilizing stereotactic radiotherapy across numerous body sites, basically from the head all the way down into the pelvis. That includes the spine, the lung, the liver, the prostate, and obviously, as our topic of our discussion today, as well as the kidney. Stereotactic radiotherapy requires that we have great imaging to take excellent pictures, and then as a radiation oncologist, I define specifically the site where the specific tumor and where the radiation will be focused on the tumor, specifically here around the red contoured left-sided kidney tumor here. We're then going to be designing and focusing and shaping the radiation treatment to basically minimize any excess radiation to the adjacent normal structures, as seen highlighted here in the orange and the yellow, namely that's the intestine or the small bowel, large bowel, and also the other parts of the normal kidney itself. We use high-level computation and calculations basically to deliver and develop and deliver a radiation plan where, as you can see here on the color wash, we're basically sculpting the high doses of radiation as tightly as possible to the red color wash tumor. And as you can see, as you move away from the kidney tumor, doses or the amount of radiation touching or hitting the adjacent structure really kind of drops off to minimal and low amounts. We completed a study at Sunnybrook and in collaboration with Dr. Swaminathan and Hamilton. It was a 30-patient prospective study, mainly for the goal of learning and be able to deliver radiation treatment in a high-quality fashion to patients in the context of a clinical study. Our main goal of the study was to determine whether or not there was an impact on patients' quality of life receiving radiotherapy, and I'm happy to say that the results of the study will be forthcoming and demonstrating that no, there's been no knockdown or detriment in patients' quality of life if they receive stereotactic radiotherapy. And this was the prelude or the pre-study that led us to the plan to opening hopefully soon across the country a phase 2 trial across multiple sites of Canada to expand the indication and utilization of SBRT for patients with primary kidney cancer in the context of a well-controlled clinical study from the West Coast all the way to across the country in Canada, where the treatment is 5 fractions of radiotherapy. That's the Canadian consensus, or at least what the radiation oncologists across the country are most comfortable with. And as I mentioned, what we're really trying to do is build on our experience in the context of a clinical trial, expanding our knowledge of our ability to deliver safe and high quality radiation treatment to centers across the country, not only at the centers of excellence or so-called academic centers, but also to centers located in the community, for example, like Grand River here in Ontario, to potential other community-based sites in British Columbia. The primary objective is local control, our ability to control the tumor with the radiation treatment, and our secondary outcomes are hopefully going to extend to include our ability to measure the impact on patients' quality of life, as well as their oncologic outcomes like disease-free survival, but more importantly, the ability of radiation to preserve or minimize any change in patients' renal function, because as I mentioned, a lot of patients with primary kidney cancer already come and see us with the diminished ability for their kidneys to work normally. This is just the eligibility criteria, and really what the take-home message of this slide is to encourage patients to ask the radiation oncologist if they're thinking, or oncologic teams, that for kidney cancers that might not be able to, that are not amenable, or the patients are not amenable to surgery or other ablative options, inquire, ask, is there a potential trial open at your local center where the possibility of radiation or stereotactic radiotherapy is possible? Hopefully you can get close to a center, at least get the advice of a radiation oncologist in the area that could advise you whether or not SBRT is a possibility for your kidney tumor. There are other trials that are open, led by Drs. Kapoor as well as Dr. Swaminathan and Hamilton, looking at a feasibility of comparing potentially radiation treatment to the other options like RFA. The key is that you consider participating in a clinical trial when we're thinking about using SBRT in the primary localized setting, or as I'll lead to in the next few slides, in the metastatic setting. So classically, cancer is defined as either localized, potentially curable, or whether it's spread or metastatic, where you see lots of lumps and bumps everywhere. And historically, this was felt to be quote unquote an incurable situation where there's no role for aggressive therapy. However, we know that in terms of kidney cancer, we know that focused high doses of radiation overcomes the whole notion or belief that renal cell carcinomas are radiation resistance. And this whole paradigm of metastases, not so much a 1 or a 0 binary change, but really it's rather a spectrum. And in terms of oligometastases, it's a state where you're in between localized, a limited number of metastases, versus this trajectory or spectrum of really diffuse metastases. And radiotherapy, in fact, like surgical mastectomy, or going in surgically to remove metastases like the liver or in the lung, is an option to non-invasively take care of these sites of metastatic disease. And in terms of indications and inquiries about SBRT, that's where radiation oncologists are playing a growing role to potentially answer that question of whether or not you can take care of sites of metastatic disease with SBRT. We have a large experience, not only at Sunnybrook in Canada, but also worldwide, of treating patients with metastatic renal cell carcinoma. My colleagues across the country are hopefully gaining more experience and gaining more knowledge and experience in designing radiotherapy plans to treat sites of metastatic disease, all the way from the brain, all the way down to the pelvis. At Sunnybrook over the last 3 years, I'm sorry the data isn't updated in 2019, but overall we treat at least 100 cases of metastatic renal cell carcinoma at our hospital or institution. So another definition in terms of metastatic renal cell carcinoma is what we call oligoprogression or oligoprogressive disease, where patients do have metastatic disease, they're on drug therapy that's controlling all the sites of metastases. However, potentially there may be 1 to 5 sites that systemic therapy. And that's where Dr. Chung, Patrick Chung at Sunnybrook, in collaboration with a few centers in Ontario and Canada, in collaboration with Garrett Bjarnason, presented their study recently at Astro a few weeks ago, where patients who were on a TKI, either sunitinib or axitinib, basically had oligoprogressive disease. Radiotherapy or stereotactic radiotherapy was directed at these specific sites of progressive metastases, and the primary outcome was to see how well were we able to control these sites of oligoprogressive METs. And the results showed so far that out of 37 patients or 57 lesions that were treated, our ability to control these tumors was 96% with no late grade 3 or 5 related treatment-related toxicities. Overall survival from the time of study to the time of exit was about 77%. And the key is that one of the take-home message from this study is that, and it's the first to show that the use of SBRT had an impact on oligoprogressive metastatic disease, is that you could delay, right, change or incidence or the utilization of the next line of systemic therapy by at least a year. So this slide is basically to highlight that we're testing new hypotheses in the utilization of SBRT, where we think that SBRT can in fact turn on the body's immune system, what we call immunomodulate, where we can turn a hostile tumor microenvironment to become quote unquote more receptive to immunotherapy drugs like ipi and nivolumab. And this is being tested and currently with an open clinical trial led by doctors Ali Khan, Swaminath, and Hott, in conjunction with Dr. Kapoor in Hamilton, the CytoShrink study, where it's testing the notion in patients with unfavorable metastatic renal cell carcinoma, can we in fact take care of the primary lesion in a new and an innovative way rather than surgically, but with SBRT. This will be a 2-to-1 randomized study. We're looking about to enroll 78 patients across a number of sites in Canada. That begins with Hamilton. Sunnybrook is just imminently about to open, and then London and Ottawa are on board and on tap to open hopefully soon in the next few months. Basically, the control arm is the standard ipi-nivo over 4 cycles with maintenance nivolumab as the standard of care arm. The experimental arm is the patients will get 1 cycle of the ipi-nivo followed by 5 fractions of the stereotactic radiotherapy, and then complete the next cycles 2, 3, and 4 of ipi-nivo. And the primary endpoint is the slide here, as you see here on your right. There will also be correlative studies such as circulating blood markers, IL-6 and other cytokines, DNA, ctDNA, and circulating DNA markers, as well as quality of life endpoints, as well as analyzing the stool microbiome as well. These are the so take-home message is, hopefully these sites will not only open in Ontario, potentially we're looking at participating sites across the country. The key question is to ask your oncology team, is this site or is this study potentially open at our site? And if not, can we speak to anyone who can provide us with more information thinking about stereotactic radiotherapy in the context of metastatic renal cell carcinoma like this trial? So that kind of brings myself to the end of my slide deck, and I'm happy to take anyone's questions. Thank you.
Well, thank you so much, Dr. Chu, for sharing that great talk with us. And I do have some questions, and I'll just refer to Mona too in just a second. Do all hospitals have SBRT capabilities? And can you hear me okay?
Not every hospital, but the majority of quote unquote centers with a hospital with a cancer center, with an active radiation treatment center, do have capabilities for the most part for stereotactic radiotherapy. Generally, those are utilized for like the big sites like lung cancer per se, right? Those are the main ones, and potentially as they extend and expand their experience in applying SBRT to other sites, like for example to the liver or the abdomen and pelvis. The next biggest one that's actually that's rolled out across centers is more utilization, at least in or interest in utilizing for potentially for prostate cancer. But the reality is that as it's still utilized in the sense in the context of a clinical trial, right?
Okay. Okay, good. Thank you. I'm going to ask you, and that's something we'd like to have on our website, is a comprehensive list of locations. Are you aware of a list, such a list that we could take advantage of, so patients across the country might have a better perspective where it's available to them?
Absolutely, be able to help you put together that list and verify across the country where at least SBRT could be utilized in the context of renal cell carcinoma for sure.
Thank you so much. Mona, do you have a question?
Nothing so far.
Okay. I do have a question from another patient. Can a patient who is has METs outside the kidney, can they still receive SBRT?
So it depends on the specific clinical scenario. I think the most important step is to review with the most responsible oncologist to be able to facilitate a conversation with a radiation oncologist. The important thing is also to know how many sites of metastases there are, what kind of drug therapy they're on, to get the whole sense of the overall picture and where the overall trajectory may or may not be going, right? Radiotherapy or SBRT is a technology that we can use, but I think there are specific clinical indications in the setting of metastatic disease that kind of either makes a patient potentially able to be considered to go through SBRT versus no, right?
Okay.
And another thing, another follow-up to that is in fact, both in the primary setting or the metastatic setting, is that none of these decisions for treatment are general, or they're not in isolation, right? These cases are in fact discussed with other oncologists, urologists, and other fellow radiation oncologists in terms of.
Okay. We lost a little bit of that answer, Dr. Chu. You were just lagging a little bit there, so we lost a little bit of that answer.
Can we maybe switch to audio, because I lost a lot of that answer, and I don't know if others are having the same issue.
Okay, so we'll just go, yeah.
Okay.
Can we do the phone thing that we had practiced?
So I will do what we practiced last night, right, Mona?
Thank you. Dr. Chu will be with us in just 1 second so we can all understand.
It's just that
I'm so glad we had a glitch. Yeah, no, that's okay. Takes the pressure off. SBRT, I think, is becoming such a valuable option for patients. You know, as we say, it's not available everywhere, but I think it's growing in popularity. There he is.
Yeah. Loud and clear.
So maybe we could just get you to repeat that answer, please, and thank you. And the question was, the METs outside the kidney, can they still receive SBRT? And we caught the very beginning, but then it kind of drifted. So
I see. The possibility exists that yes, but every case, whether it's the primary or in the metastatic setting, should be discussed in a multidisciplinary case conference with fellow oncologists, urologists, medical oncologists, and the radiation oncologist in the room. That's our general approach. And it's difficult without knowing the patient's specific history, both in terms of the number of metastases, where they are, and what kind of drug therapy they've had or will be having, and how they're changing over time. These are questions that need to be answered before you can actually reach a final decision about going ahead with SBRT, either to 1 or 2 up to 5 spots or not.
Okay, thank you. I have another question. There was mentioned a little bit earlier in the forum about treating a very small tumor with SBRT. So kind of maybe a T1 or T2. Is this something new, or has this been going for a while? And what can you share with us about, these small localized tumors? Is it an option?
So small localized tumor in a primary biopsy proven kidney cancer, is that the question?
Yes.
Yeah. So as I mentioned before, the standard of care for these small kidney cancers is still surgery, right? Whether it's a partial total nephrectomy, but ultimately the question is surgery, and they should be meeting a urologist for these small renal cancers. When they're small or T1As or less than 3 centimeters in size, then other options include thermal ablation, and that includes radiofrequency ablation or cryotherapy, depending on the center and their level of specialization and experience with those thermoablative options. Radiotherapy, in terms of the small renal masses, as we've been growing our experience, at least at Sunnybrook and some of the centers in Ontario and more so across Canada, is that we generally reserve or think about SBRT for lesions that have been growing over a period of time radiologically. Ideally, you have a biopsy that shows it's a kidney cancer. And generally, we would like to follow them. And if they're growing over time to more than 3 to 4 centimeters in size, that's when we would think about having a conversation about SBRT, right?
Okay. So not necessarily.
And then obviously it depends on whether or not the specific center has a specific protocol and experience to go ahead to deliver that course of radiotherapy treatment, right?
Yes, yes. Maybe you can share with us just a little more specifically. I think there's concern, and this is a little bit off topic for kidney, but it can be relatable. I was working with a patient that had a tumor in their chest that was very close to their heart, and there was talk of SBRT. Is that possible with these sensitive organs? Like, if metastases goes to the lung and metastases goes to other areas where they're sensitive organs, is SBRT still possible?
I think that's it's an excellent question, right? It depends on where in the body that lump is or the target is per se, right? We can potentially focus radiotherapy to really any lump or bump in the body, but it's really in real estate, the geography and location, what's close to that tumor that might be potentially at risk of radiation damage. And that's always the key question that we always ask, right? So without knowing the specific details of that case, where in the chest or mediastinum and how close it is to the heart, it's really difficult to say, but just listening to it, yeah, the heart is a vital organ. And in that area, if a tumor is in and around the heart, one of the challenges that we have in terms of SBRT is movement or organ motion that kind of causes the tumor to kind of jiggle, right? And we have to factor that into our radiation plan and how much dose or how much radiation we can actually safely deliver, right?
Excellent, because you don't think of these things as a patient. Your heart is constantly moving, and your lungs are moving as well. So you don't think of these little intricacies of doing SBRT.
That's right. Even in terms of the kidney itself, or the kidney focusing SBRT for kidney cancers, is organ motion above and below the diaphragm happens, right? And that's correlated with your respiratory cycle. If you think about your lungs as 2 bellows or a big big sacs of air, everything moves throughout the respiratory cycle, and everything below the diaphragm, including the kidney, kind of moves with it, right? And that's one of the challenges and the technology has allowed us to basically try to adapt and overcome that, to take that into account, to minimize the amount of motion. We're able to deliver and focus the radiation to that kidney tumor. But that's something that we can think about, and that we assess for every patient, right, is the overall extent of the movement and how big of a quote-unquote margin we need to account for. And that margin potentially impacts what the dose of radiation is to, say, for example, the picture I showed, that left-sided kidney tumors. When you think about motion, not only the tumor itself, but how close and how much is it moving relative to the intestines, right?
Yes, yes. Oh, so many aspects to be thinking about, for sure. And we as lay people don't take that into consideration. We just think, okay, you can go in and zap that little tumor and it'll be all done. But it's very intricate work. I see. But thank you for sharing that. Mona, do you have any questions for us, or are we all cleaned up?
No, I have a question. It is,
Okay.
Brian is completing immunotherapy with a 40% reduction of lymph nodes. Can SBRT be used on metastatic lymph nodes?
That's an excellent question. It's difficult when you hear a percentage. It depends on how many lymph nodes he started with, right? Where they are, if they're close together or far apart within the body. So I think ideally, to answer that question, I need to see, and a picture paints 1,000 words, right? And that's why scans and CT scans are important and vital, and part of that pathway or decision making for SBRT, right?
Right. Very good. Well, Dr. Chu, I thank you so much for joining us today. It was a valuable part of our forum, and we look forward to getting more information. I'll look forward to that list so we can provide it for our patient community. So thank you so much for joining us.